specialized laboratory. Francis Owino in Nairobi for quite of time and has an organization. Has a lot of information in hematology and transfusion. Free to interact with him, be free, and also be free to gain any guidance. You can, in case after webinar, you can always contact the LMSK and it can lead you. So welcome. Welcome. Thank you.
Good evening, everyone. Marcus, would you confirm if I'm audible?
Good evening.
I'm audible. Okay, so we'll start. Today we look at optimizing patient outcomes through appropriate blood component selection. So in this webinar, we're just going to look at proper utilization of various blood components, some of the indications, contraindications, where should you give what products and in what situation. And in the first part of the webinar, we look at we'll put much emphasis on general principle of transfusion. So maybe just things that we need to have in place for us to have a good transfusion practice generally. So that will cover in the few first slides. And then in the last part of it, we'll put much emphasis on the specific product so that we see if it is red cell concentrate, for example, where is it needed? If it is plasma components, in what conditions do you need them, and what is the time, and when do you need to transfuse? So the key thing is that transfusions will be of maximum benefit to the recipient, and it should be of maximum benefit to the recipient. So if there is alternative to it, then we avoid to transfuse where it is not needed. So therefore, the objectives for today's webinar will be: one, to understand the blood components, to identify appropriate indications and apply safe transfusion practice. And those three are very key. So the risk must outweigh the benefit. That is, the risk of the transfusion has to outweigh the benefits. So this one rests with the requesting clinician and the physicians. So the physician or that particular doctor that is requested for this particular transfusion must have done risk assessment, and in their best knowledge, it is the transfusion that will be of best option in that particular case. And if there's an alternative, then they will go for alternative. Like if the patient is dehydrated to an extent that they need a plasma transfusion, then they must outweigh. If it is something that can just be salvaged by other volume expanders like albumin or giving fluids like normal saline, then they would consider the alternative. So the risk must outweigh the benefit. And then the next one is use of right product to the right patient at the right time. So that is the key thing. The three R's. That is the right product, right patient at the right time. So here is a teamwork, which means the right product selection. So it means that the doctor must ensure that the products that we are giving meet the clinical conditions, clinical needs of the patient. If the patient is anemic, for example, then the best product to give in that case would be packed red cells. And then the right patient, which means we must do proper patient identifications all the way from the ward to when they are giving this particular administration to the lab, whoever is collecting that particular samples, and again to the lab, to the people processing those particular units and issuing. So everything has to be done right. So we must match the product to the patient at every given point we move with this particular blood component, and then at the right time. when do we give it? Are we going to delay it so far that by the time we are giving this particular transfusion, it is no longer needed, or the patient have even died? So those are the things that we need to look at. Those are the things that we need to put much emphasis. So the emphasis is use of the right product to the right patient at the right time. And then the third one, blood should be transfused only when required to save a life. So only at that point where it is required to save a life, then you transfuse blood. Then the decision to transfuse should be based on an estimate of the patient risk for developing complications of inadequate tissue oxygen delivery. Then the decision to transfuse must be based on both the hematological and the clinical status of the patient. So as we have said, that decision to transfuse this particular patient should be based on the estimate of the patient risk for developing complications of inadequate tissue oxygen delivery, like in the anemic case, where the patient is severely anemic and they direly need that particular transfusion. And so therefore we need to give the transfusion, the HB is less than 6, and so therefore the patient has to be transfused. So in other cases, you also assessed both hematologic, that is the lab finding, and also the clinical status. So if the patient clinically stable, the patient could be anemic but clinically stable and can be managed by alternatives. So those are the things that the doctors have to look at, or the questions that they have to ask themselves before they can decide to transfuse. Then the risk associated with transfusion can be reduced by one, effective blood donor selection. So if we have done the blood donor selections properly, then we reduce the risk. And the blood donor selections here, we are talking about screening of this particular donor. So the blood donor questionnaire should be tailored in a way that you are able to conduct the donor risk assessment. So this donor risk assessment is also able to help us to know the appropriate donors, so that we don't have recruiting donors who could be in Windows period in HIV, and even with the screening we might miss and end up transfusing an HIV positive blood to our patients. And then screening for TTIs in the blood donor population, that will be very key in protecting our recipients or the patients to from contracting the transfusion transmitted infections such as HIV, hepatitis, and VDRL. And this should be done using higher techniques like ELISA or even PCR, where such is available. And then high quality blood grouping and also compatibility testing. So that is also very key, that we screen for TTI. And of course, blood grouping is very key in transfusion. Even if the PINES comes written A positive, you cannot assume that the blood group is already known. Even if the patient says that I'm normally blood group O. In transfusion, there is no assumption. So we'll have to perform the high quality blood grouping to confirm the grouping of both the donor and the recipient, so that you ensure that we give the right unit to the recipients. And of course, compatibility, just to rule out allo immunization in the recipient, and to ensure that the recipient is safe to receive that particular transfusion, that our recipients have not been sensitized, or they have not produced antibodies that would rather, instead of the transfusion helping the patient, but now the patient already have antibodies in their system that will destroy the donor transfused donor cells. And then the next one is component separation and storage. So again, the integrity of the blood components that we prepare, that is the plasma products, the platelet products, the cryoprecipitated, are they stored in the right conditions and are they prepared in the right way? And then appropriate clinical use of blood and blood products. As we have said, you only transfuse where necessary. So the questions that we had introduced earlier in terms of hematological status of the patient, as well as the clinical status of the patient. So it is the doctor to ensure that the risk must outweigh the benefit, and that transfusion is fit for that purpose. And of course, quality assurance, that ensure that every procedure we are carrying out in that case meet the standard, meet the set quality standards. And then the next one is blood component preparation and transfusion therapy. So selection of ABO compatible red cells containing components and plasma is essential to prevent reactions and optimize component therapy, and is summarized in the table that follows. So this recipient ABO, for example, if the patient is blood group A, then in the order of priority, if it is whole blood, it's best advisable that you give those particular patients the same type, that is blood group A. But if it is packed red cells, because at least packed red cells, most of the plasma have been removed, the first priority would be blood group A and then O. But if you are transfusing plasma products, platelets, or even FFP, then it is the other way around. You give A or AB. And you know, because the AB, why we are giving the AB plasma is because this particular plasma do not have antibodies in their system. That's why it is of priority in that case. And then if the recipient is blood group B, if it is all blood, as we have said, the best thing is to give them their own blood type, that is blood group B. And if it is packed red cells, you start with B. And if you don't have that in your store, then you give O. So, you know, most of the time we tend to misuse O, and most people will just tend to give if there is one blood that we need one type that we need proper inventory practice, or rather management, is the type O, because type O is a universal donor, and it can save a lot. It can save a lot in terms of in events of emergency situation. So if you just give without considering the selection protocol, then you might end up giving a lot of O's, and then when you have an emergency, you don't have any O left, and you are left with several A's and B's that not. Like, remember, these patients who are blood group O, they cannot receive from any other blood type. So we really need to control that in our labs. Then if the patient is blood group AB, they can receive from AB all blood. Of course, these ones are universal recipient, but you'll order you'll give in the order of priority, and that is AB. If you don't have AB, then you can move to A, and then B, and then the list is O. That somebody would ask why B comes before O. Remember, the ones which are, the blood group A type, they have got several, a lot of most of their H precursor subterms. Remember how the A antigen is formed. I will not go into the biochemistry of that, but most of those H precursor subterms on their surface, the H antigen on the red cell surface, have been converted into A. And like B cell, B blood group system, where the amount of H antigen is greater than that in A. So if it means that if this particular patient would have been sensitized against or have developed some anti-H, they can still have some transfusion reactions in that caused by the anti-H in their system. And that's why you are seeing, if it is AB, then you give A, and then B, and then last option should be O. Because of course, O, what they have on their red cell antigens, red cell surface is O. And of course, for plasma, you only give them AB. You would not want to give any other plasma. And then if the patient is a blood group O, then all blood you give O, and then for the packed red cells, you give O. And of course, for the plasma products, they can receive from all other groups, but in that order of priority. So the ABO compatible cryo is not required, because so when it's come to cryo, there's very small amount of plasma, and compatibility testing is necessary for all products containing red cells, including the granulocytes. So any other product that contains the red cells, you must ensure that it matches that of the patient. So that's why compatibility testing is very key. So I would want us to move a bit faster at this point. So maybe you just remain focused on the slide so that I don't lose you along the way. So in this slide, I'm going to look at the principle of clinical transfusion practice. So as we have said, avoid blood transfusion unless it is required to save a life, or where the risk outweigh the benefit. So the next one is prevention and early diagnosis and treatment of anemia and underlying condition. That means if we detect anemia early, we can manage using alternatives such as imatinib. And in that case, we may not require to transfuse these particular patients. And you can also use alternative to transfusion such as IV fluids, and then good anesthetics and surgical management to minimize blood loss. So that is for the surgeons or the people who operate in the theater. So if they adhere to good anesthetics and surgical management, then there will be minimized blood loss, and that means the patient may not require transfusion. So prescribing should be based on national guidelines. It should not just be given anyhow. If at all we are to transfuse, then it has to be based on national blood guidelines on the clinical use of blood, taking individual patient needs into account. So of course, we are not just going to look at the national guidelines alone, as you transfuse based on the set guidelines, but you also take into account the individual patient needs, and that's so that you give them the right products that they need. Then the HB level should not be the sole deciding factor. You should also factor in the clinical evaluation of the patient, and we had also discussed that. Then again, let the patients be aware that there is a transfusion. Don't let this not come as a surprise to them. So the consent form to be obtained from the patient before transfusion, and then the clinician should record the reason for transfusion clearly. So let the clinicians record the reason for transfusion clearly, and a trained person should monitor the transfused patient, and if any adverse effects occur, respond immediately. So again, as we have said, the three things: the clinician should record the reason for transfusion and the products that they want, and then seek consent from the patient. It has to be an informed consent, and also the nurse should monitor, a trained person. I think there should be someone to monitor the patient during the transfusion period. So what informed consent means is that the patient should be informed that transfusion of blood or blood component is a possible element of the planned medical or surgical intervention. If they are due for surgery, then and the doctor needs feel that this particular, maybe it is major surgery where transfusion is not inevitable, like you cannot avoid transfusion. So let the patients know that one of the elements that they would require is transfusion, or you are managing a condition and you feel that at this particular point, this patient will require transfusion. So they should be aware. So the patient should be informed about the risk, the benefits, and the available alternative to transfusion. And then the consent form, that one is a doctor responsibility to ensure that these particular patients have been given, or rather they have obtained informed consent from the patient before we can go ahead and transfuse. So transfuse blood only when necessary. We have said that. So when should we transfuse blood, and what blood component should be transfused? So by answering that question, now we look at the various components, blood products, and then we look, we see this one best fit where, or in what situation do we need that. So one is whole blood transfusion. So in whole blood is the complete collection of a single donation of blood, which means in this whole blood we'll have red cells, granulocytes, platelets, and all the plasma proteins. But as a result of the storage, there is loss of activity by the coagulant factors 5 and factor 8. Of course, you know these are labile factors, and so therefore in about 6 to 8 hours, you would have. Remember, that's why we are saying when we are preparing when we prepare the fresh frozen plasma, you need to use fresh whole blood that are 6 to 8 hours old, so that you are able to capture the coagulation factors. Because remember, these labile factors such as factor 5 and factor 8, you need them. And if your fresh frozen plasma is going to be prepared by whole blood that has overstayed maybe for 24 hours, then you'll have other coagulation factors, yes, but they'll be deficient of the labile factor 5 and factor 8. And if that particular patient is an hemophilic patient, let's say they're having hemophilic type B, then that is factor 8 deficiency, then that particular product could not be beneficial to that particular patient. And so therefore, maybe in that case, you may need to consider having a cryoprecipitate transfusing that particular patient with cryoprecipitate. Remember, cryoprecipitate also we prepare from the plus FFP. So in that case, you will really need a very fresh whole blood so that you are able to get your plasma and prepare the cryoprecipitate from it. So colloids and crystalloids also, those ones also lose their activity. Then indications for whole blood, we only use whole blood in cases of trauma, exchange transfusion, and massive blood loss. So it may be in cases of also in postpartum hemorrhage. So you see, if you use whole blood, then you don't need to transfuse again the equal volume of FFP. But if you're going to use RBCs in massive blood transfusion, we'll also do a webinar. There'll be another topic we will cover for massive blood transfusion protocols and also in LCM transfusion so that we get to understand. So if it is all blood, if it is FFP, then you will need, if it is packed red cells, then you will need to compensate with the same amount of, if you're given 4 units of packed red cells, then you need to compensate with the 4 units of FFP. So what are the contraindications? Use filters. Platelet coagulation first will not to be active after 3 to 5 days. Then donor and recipient must be ABO identical. So those are some of the things that you need to consider. Use of filter will just help you to reduce that particular whole blood. And then the volume is normally 350 to 450 ml and collected into a double tip, depending on which particular bag you are using. The anticoagulant is CPDA, and you're supposed to separate within 5 to 8 hours, as we have said. We've given a good reason as to why we are doing that. So that is done by differential centrifugation, which is programmed by 2 speeds. So every you start with the heavy speed for about 10 to 15, then the light speed for about 1,500 for 5 to 7 minutes. Then red cell transfusions contains hemoglobin, serving as the primary agent for transport of oxygen to tissue. So for the anemic patients, the best product for them is red cell transfusion. So these are used to restore the oxygen carrying capacity in patients with anemia or blood loss, where alternative treatments are ineffective or inappropriate. And so, because we said you only give it where it's necessary, and that's why that disclaimer is there, that where alternative, which in this case, our patient is anemic, and we cannot salvage this by, let's say the patient is having an HB of 3. So we can't say we are going to treat, we are going to give iron, we are going to give folate to boost that HB to a point of, so it means we have to transfuse in that particular case, at least to restore the oxygen carrying capacity in that particular patient. So one thing we need to do is typing of RBC, that is the blood group for both ABO and the rest, to determine for both the donor and the recipient. So it means we have to know the blood group type for the donor and the recipient for the purpose of cross match. And then we screen for RBCs for atypical antibodies, that is the cross match. The cross match is just to check where the patient has been allo-immunized, or these particular patients have produced antibodies that would in turn destroy the donor's red cells. So approximately 1 to 2 patients have these particular antibodies. So it is a rare finding, but especially if a patient has been multiply transfused, they're likely to be allo-immunized, and we're likely to find some transfusion reactions. So donor cells and recipient serums are mixed and evaluated for agglutination. That is basically what happens at the cross match. And of course, you know, the 4 phases of cross match is very key, because we know what we are investigating in every phase. If it is SRT, then our interest is on IgM, that is ABO incompatibility. And then now, if we talk about S37, there we are looking at the warm antibodies, the IgG, so resus antibodies and other blood group system. And talk about albumin. Albumin phase, the A37 is just an enhancement and enhancement. It will enhance the antibody reaction, so that in case there is a reaction, it will lower the electric constant and make them the antigen antibody reaction to be effective and form agglutination. And of course, finally, the AHG, the most important phase, because the AHG will tend to, if at all there is any sensitization of the red cells, then they will be able to form the cross-linking between those 2 particular agglutinases and give us a positive lattice that we are able to observe microscopically in the lab. So you store at 4 degrees Celsius for up to 45 days. It can also be frozen, the RBC concentrate. So indications, when do you give the red cell transfusion? So for red cell transfusions, generally, if the HB is less than 7, but again, that will depend on your locality, will depend on that population, will depend on the clinical status of the patient. Because this patient could be sickle cell patient. If they're having an HB of 7, you don't need to transfuse them. So again, as we had said, that transfusion decision is not just based on the HB alone, but also on the clinical status of the patient. In cases of acute blood loss, maybe it was surgical procedure or it is an accident where there is greater than 1,000 ml within few hours. With symptoms or no symptoms of hypovolemic shock, you may want to give red cell concentrate. Then perioperative with intraoperative loss of greater than 750 ml, there is an indication for that. So again, the surgeon need to estimate this particular procedure, what blood loss am I likely to incur. So if it is a major procedure, then they will know this particular procedure, this is the kind of blood loss that we are expecting. And in that case, they will prepare the patient prior to the operations. And so the blood products has to be ready before they start the procedure. And remember, we have also advocate for bed surgical bed surgical and anesthetic management so that we minimize the blood loss. So perioperative with HB less, so this patient is due for theater and they're having their HB less than 8, which means they are already anemic. And maybe this procedure is very key in rescuing the patient. It's not something that can be avoided, and it means the doctor will have no option but to do the procedure, but with transfusion. So in cases of iron deficiencies, megaloblastic anemia, only without, so where the patients are having iron deficiency, megaloblastic anemia, this particular patient is non-responsive to pharmacologic therapy, such as iron, B12 or folate, then in that case, there's an indication for red cell concentrate. In cases of severe decompensated symptoms like tachycardia, dyspnea, severe dizziness, and also in severe anemia cases where the HB is less than 5. So for acute blood loss, when the adequate fluid resuscitation has failed too. So in acute, yes, it could be an accident, it could be acute blood loss even during surgery and all that. The surgical procedure is over, but the patient have suffered acute blood loss. And in that case, we have failed to correct intravascular volume depletion. It has failed to relieve symptoms or stabilize vital signs. So in such a case, again, that will be an indication of transfusion. Then in cases of chronic blood loss, to relieve symptoms when appropriate medical measures to improve the red cell mass are inadequate, and also patients under anesthesia should be based upon stability of vital signs. So when it's come to operations and all those clinical management, that will really depend on the situation of the patient and also the team that is managing the patient. And this has to be done in a timely manner so that you are able to save our particular patients. So what are some of the considerations that we look at? The recipient must not have antibodies to donor RBCs, and that's where now the cross-match comes in, because it's through the cross-match that will ensure that these particular patients do not have antibodies that is directed to the against the donor cells. Then use the dose if you want to know what you are going to give. It should be 10 cc per kg, and that will increase the HB by 2.5 gram per deciliter. So just how the doctor would arrive, I need 2 pints, I need 3 pints, I need 4 pints, you see? Yeah. So usually transfuse over 2 to 4 hours, and it means 10 cc per kg, and then of course the patient is having an HB of 2, for example. So this doctor want to increase this particular HB from 2 to even 8. So it means that what is the deficit? It's around 4 grams. So based on that, you'll know what meals do I need. So if you do that math, you'll be able to know whether you will need to transfuse 2 pints or you need to transfuse 3 pints. So transfusion for red cell should be done over 2 to 4 hours, slower for chronic anemia. Then contraindication, red cell containing components should should not be used to treat anemia that can be corrected with specific imatinib medication. So maybe the patient is having an HB of 9, an HB of 8, or even 7. It's not that severe and they're clinically stable. That case you can correct using imatinib. And in that case where you can use the vitamin B12, the folate and the ferric, you don't need to transfuse in that case. Yeah, so those are the contraindications. So in this particular slide, we're just looking at the storage, which we are all acquainted with. So for packed red cells, the optimum temperature is 4, but plus or minus 2. If you use CPDA, then the duration is 35 days, but that can be lengthened if at all you are having the additive solutions such as Sagam, which can extend it to 42 days. We also have those particular red cells which are irradiated. So if it is an open system, you give within 24 hours, original expiration, or 28 days from the date of irradiation, whichever is earlier. And then in some cases, especially in patients which are having we call this one, this transfusion reaction I'm looking for, mostly, especially patients which are having hypersensitivity reactions. And these particular patients have got a lot of IgA and all that. So in such cases, we give them saline washed RBCs. So if you are having saline washed RBCs, you give them saline washed RBCs, you give within 24 hours. And also in neonate, you transfuse within 24 hours to avoid hyperkalemia. This is still goes for RBCs that are irradiated. Then we have got frozen RBCs. This one is, I don't know whether in Kenya we do freeze any, but for those ones who are working in maybe in other countries that are developing, they have got a rare donor registry. So let's say, for example, you want KIL negative blood. You see, those are rare. You not just announce today and you get a donor for that. So for those rare donor registry, you might want to freeze them, and you can freeze that up to 10 years. So the frozen RBCs either mostly they are given 40% cryoprotective agent, that is glycerol. So it could be 40% or 20%, and that can be stored at -65 if 40% glycerol, and can be stored up to 10 years. And if it is, remember, we have said you had that glycerol, which is a cryoprotective agent, to keep those particular cells intact so that you are able to transfuse them when you need to do so. And then, so at that point of transfusing these frozen RBCs, you need to deglycerolyze them, which means you remove the glycerol that was used to protect them. At that point, once that has been done, it is stored at 4 degrees Celsius, and if it is open system, you can give within 24 hours. If it is closed system, you can give within 14 days. Rejuvenated RBC, those are the ones which you've added additive solutions, and so therefore you can give that less than within 42 days, which means the RBCs, it might have passed the 35 days, but still within the 42 days, so you give within 24 hours. So the wash rejuvenated RBCs and the one that you've removed glycerol, and then the rejuvenated RBCs, and also the frozen one, which means you've added additive and you want to freeze again, you can store for 10 years. So that is all about the RBCs transfusion. That is the packed red cells. We look at the storage conditions for various products in that category. And we've also covered the consideration as well as contraindications. We'll talk a little bit more about platelets now. So platelets are very essential for normal hemostasis. You know, it's responsible for the formation of the primary hemostatic blood. So we need platelets if we are going to control bleeding. So platelet transfusion is indicated for the treatment or prevention of bleeding in patients with low platelet count. That is thrombocytopenia, or where the patient could be having the normal platelet count, but still the platelet is not functioning normally. So that is platelet dysfunction. And then so the patients which could be having the qualitative platelet defects, like the ones for Bernard-Soulier syndrome, things like that. And then platelets have ABO antigens on their surfaces and may have reduced survival if transfused transfuse to an ABO incompatible. So again, it's also possible to, it's very key that you give platelet units that are compatible to the patient's their own blood type. So if it is their blood group A, then you give them blood group A platelet. Although this is not usually clinically significant, but it's key because you never know, that patient could have been, the challenge comes when the patient has already been sensitized and they already have antibodies. So any slight trigger can cause a transfusion reactions. So platelets are produced in two ways: the whole blood donations that are centrifuge, and the Buffy-Cort, that is between the red blood cells and the plasma layer. And those are the ones that we know. Another way is through apheresis. So you can go the conventional way, where we centrifuge, harvest our plasma, centrifuge the plasma again, then harvest our platelets. So we can get it directly through apheresis. And then preparation of platelets. Prepare from individual units of all blood by centrifugation. So which means each bag will have about 50 to 60 ml of platelet, and that will give raise the count by 5.5. And another therapeutic dose. If you are going to use the conventional platelets, the ones that we prepare through the centrifugation, then you might need several units, unlike for the apheretic platelet. So another therapeutic dose of platelets is obtained from a single donor by apheresis or from pooled donation, 4 single bags. So which means you need at least 4 single bags for the conventional one, but the one for the donor, the one for apheretic, you may just need 1. It's enough because it will raise it with about 50,000. Then collected from an individual donor during 2 to 3 hours. So that's now apheretic procedures. It explains the apheretic procedure. It can take 2 to 3 hours depending on the donor. In this one, you don't need several donors. Unlike for the conventional method, you just need 1 donor, and the volume for that is 200 to 300 ml. And you can have it around, mostly you will have this around 2 units of platelets. Male donors are preferred to reduce the risk of transfusion-related acute lung injury. And the shelf life, of course, is 5 days, so 5 to 7 days at constant agitation, and you keep them at room temperature. So what are the indications for platelet transfusion? The decision to transfuse should not be based on just low platelet count alone. So one is BIC with active bleeding. So this patient is having disseminated intravascular coagulation, which means we are dealing with the case of thrombosis, and they are also bleeding. So the platelet count again is low, is less than 20,000. In that case, you need a platelet transfusion. So the second indication is severe thrombocytopenia, and that could be following chemotherapy. So this could be a cancer patient, and they are on chemo, but however, they have developed thrombocytopenia and the platelet count are less than 10,000. So in such a case, we transfuse. So the next one is active bleeding with severe thrombocytopenia. So this is just a normal patient, and they are actively bleeding and they are having thrombocytopenia. So in that case, again, we transfuse. So the next one is thrombocytopenia with scheduled invasive procedure. So the patient is having thrombocytopenia and they're supposed to undergo a surgical procedure. So, and also in other cases, they could be having other comorbidities like leukemia, myelodysplasia, aplastic anemia, and also solid tumors. So contraindications where you are not supposed to transfuse platelets. Do not if bleeding is unrelated to decreased number of or abnormally functioning platelets. So in such a case where the patient is having the thrombocytopenia, but the bleeding is associated with the abnormally functioning platelets, or it is unrelated to decreased number, that in that case we don't transfuse. So do not use in patient with activated or autoimmune destruction. If the patient is thrombocytopenic and it is idiopathic, or it is confirmed case of autoimmune destructions, like in cases of thrombocytopenic purpura. In such case, we don't transfuse. So which means in that case, you will go for alternative management, which means we get rid of the irregular antibodies that are destroying this particular this particular platelet. You will give things like albumin, or you will give fluids or you can do FFPs if you have to, or use the blood component in such a case. So in other cases that you don't transfuse again is in heparin-induced thrombocytopenia, because even if you continue transfusing, again, those antibodies are still in the system and they keep destroying the incoming platelets from the donor. The next one is in immune thrombocytopenia, like where the patient have produce antibodies against their own platelets. It could be autoimmune or alloimmune. So in immune thrombocytopenia, again, you don't transfuse, and you also don't give it prophylactically in most patients with aplastic anemia. So as we said, the clinical decision transfusion should be based on the clinical status of the patient. Again, in thrombocytopenic purpura, that is mostly where the patients have developed antibodies to destroy the donor platelets, and in turn, the antibody is also able to destroy the patient's own platelets, and so they will develop what? Thrombocytopenia at the end of the day. The hemolytic uremic syndrome or eclampsia, unless the patient has a life-threatening hemorrhage, then you may want to transfuse. So in terms of dosage, the therapeutic dose is 1 unit of apheretic platelets or 4 to 6 units of all blood-derived platelets, either of which usually contain about that number of platelets. And one consideration is they contain leukocytes and cytokines, and 1 unit per 10 kg of body weight will increase the platelet count by 50,000, and that is the one for apheretic. And so if we are talking about the conventional platelets, then you will need about 4 to 6 units of that. So the donor and the recipient ABO must be identical, which means you only give the patients their own type or that matches them. So in cases where you are dealing with special group of patients, and you may want to, maybe you are dealing with a patient who have received a bone marrow transplant. You know, in that case, you are trying to reduce chances of transfusion associated graft versus host disease as much as you can. Or you are dealing with a neonate, or you are doing the intrauterine transfusion. In such a case, maybe the patient have, the mother is pregnant with the baby, the fetus who have developed HDFN, the hemolytic disease of the fetus and the newborn, and the doctor want to rescue this particular growing fetus because they have already developed anemia and all that, and so therefore transfusion is necessary. So if you are going to do intrauterine transfusion, irrespective of the product you are going to use, they have to be irradiated. And also in those special cases, like we have said, severely immunocompromised patients, you would not want them to develop graft versus host disease. So you irradiate platelets. You can use irradiated platelets, maybe actually to prevent the transfusion associated graft versus host disease in those scenarios that we have explained. And then platelets in additive solution. After washing to remove most of the plasma platelets that is suspended. So maybe this one is possible in cases where you are giving platelet transfusions in, especially the ones we talk about in the ones we've talked about, the ones in immune, the ones in immune thrombocytopenia and all that. So you want to do away with the plasma as much as possible. So those ones are, and also in these cases where you find that it is the donor antibodies destroying the patient platelets. So again, in such a case, you can use washed platelets. So which means you remove the plasma and then you resuspend your platelets in platelet additive solution. So this is possible for patients with recurrent severe allergic or febrile reaction. Actually, the reaction I was looking for is the febrile non-hemolytic transfusion reactions. And I wanted to explain about washed RBC under the RBC concentrate. Yeah. So again, in such a case, if you're having patients with such cases, then you would want washed products, saline washed products, or in platelets, you have said you use platelet additive solution. I've not used it before. So this is for patient recurrent severe allergic or febrile reaction to standard platelet transfusion. So the shelf life is reduced to 24 hours after preparation. So you've used the washed platelet solution, platelets products, you will not go there the 5 days. you'll reduce it to, you will give that unit within 24 hours. Then the next one is HLA selected platelets. So this is the kind of patient with the refractory to random platelets component. So you find that a patient is having refractory thrombocytopenia. There's a friend of mine who was doing a research in that area. So this particular patient has got HLA alloimmunization. So it means that irrespective of the platelets that the transfusion that we do, then they keep on the antibodies, the HLA antibodies keep on destroying their platelets. So we are transfusing, and it's not really salvaging the situation, which means if the patient is having a platelets of 200, they keep on at 200, or they're even going lower. They are always at 10, 20, and still transfusion has been given. So in such a case, it is refractory, and it is not resolving. We may want to give specific HLA platelets. So it means we have to type and do the HLA cross match and find this particular patient the products that are compatible with their system. So leukocyte reduce again is recommended, especially if you are doing apheretic platelets. Those are already leukoreduced. That's why apheretic platelets is mostly referred, because it will be beneficial to the patient. At the same time, you will not need several donors, and you will also not need several units of platelets compared to the conventional methods. I would not really want to go much into this table because we are all aware of it. It's all about storage of platelets components, 20 to 20. We know we store at room temperature with the constant agitation. Then the expiry range from 24 hours to 5 days, depending on the collection system. Then these other ones are just talking about the special treatment. We talk about the radiated platelets, the leukocyte reduced, the pooled platelets. If it is an open system, you give within 4 hours. Within 4 hours. If it is closed system, then you can no change in expiry date. But if it is open, that is the same to all of them. It's the product. If you've pooled and it is an open system, you give within 4 hours. If it is closed system, you can give within 5 days. So the next one we'll talk about is plasma transfusion. We've covered the red cell transfusion, we've also covered the platelet transfusion. So let's talk about the plasma transfusion. So you see the plasma is the acquired part of the blood, and this can be derived from separation of a whole blood, collection, or even by apheresis. You can do it by the conventional method where we centrifuge, get our plasma. So that plasma, you can have platelet poor plasma, platelet rich plasma. Of course, if you are going to stop at FFP, that will be platelet rich plasma. But if you are going to extract again from the plasma, then we get the platelets, then it will be platelet poor plasma. And of course, the key thing to consider again is the timing of the whole blood that you are using to prepare those particular components, depending. So that's why if you look at how this other system works, FFP only refers to those particular plasma that were prepared within 6 to 8 hours. Then if you are talking about a unit that was plasma that was prepared with a unit that's overstayed for 24 hours, then it should be plasma frozen after 24 hours, something of that. So just to guide the person who will be issuing to know, okay, as much as I'm giving this FFP, it will be deficient of the labile factors. So the important element in plasma will include albumin. They are rich in albumin, coagulation factor, the fibrinolytic proteins, immunoglobulins, and other proteins. So once plasma is collected, it can be frozen. So we have got the fresh frozen plasma, and this fresh frozen plasma, if thawed at 1 to 6 degrees, we can end up with that. We prepare our cryoprecipitate. Cryoprecipitate, means you get your fresh frozen plasma, then you thaw at 1 to 6 degrees. Then you remove the cryoprecipitate by centrifugation of the same. Then you will express the supernatant plasma, and that can be refrozen, but you will now cryoprecipitate poor, because it's not having much of the contents of the cryoprecipitate, like fibrinogen, factor 8, and all that. That is removed. So we remove, by doing that, we thaw at 1 to 6 so that we centrifuge that particular FFP and obtain our cryoprecipitate. You can refrozen the plasma, and label as plasma cryoprecipitate reduced. So for the FFP, it will serve as a source of plasma proteins for patients who are deficient or have defective plasma proteins. So FFP contain high levels of the labile coagulation factor 5 and factor 8. And that one has a disclaimer, which means we said that's why we call it fresh frozen plasma. So again, the timing of preparation, you really have to take account of that, so that your unit, if you are saying it is fresh frozen plasma, then it has those labile coagulation factors. So the volume is about 200 mils. Generally accepted starting dose is 2 units or 10 mil per kg for coagulation replacement. You can store at -18 or even -20, depending on your SOP for a year for 12 months. So what are some of the indications? When do we transfuse the fresh frozen plasma? One is preoperative or bleeding patients who require. Remember, the patient could be going about open heart surgery, so you will need all these products. You need platelets, you need plasma, you need FFPs, you need the red cell concentrates. So again, the patient is bleeding, and you require to replace multiple plasma coagulation factors. So in such a case, you will give the FFPs, or the patient is having a liver disease. Remember, most of the coagulation factors are from the liver. And of course, if the patient is having liver disease, then this particular patient will likely to suffer from, to be deficient of several coagulation factors. And so therefore, the best product for that will be FFP. Or this particular patient could be having DIC. Again, could be having DIC, you give FFP. So patients undergoing, remember the reason why we are giving FFP, remember in DIC there is consumptive, there is an overconsumption of the coagulation factors. And that's what's caused about those prolonged APTT and PTTs in DIC. So patients undergoing massive transfusions who have clinically significant coagulation deficiency. Again, in massive transfusion, we will still give FFPs, because remember, if you're just going to pump red cells without taking care of FFP, you are going to lead to dilution, or we call it what? Coagulation deficiency, coagulation factors deficiencies. Because of what? You are diluting the system further. So therefore, we need to take care of that. We have to balance that. So it means if you give 4 units, then also need to give the same on FFP and also on the platelets. Huh? Yes. So patients taking warfarin. So if you need immediate reversal, maybe this patient is supposed to undergo, they're on warfarin and they're supposed to undergo a procedure. So you need immediate reversal of the warfarin effect, then you give FFP. So patients taking warfarin who are bleeding or need to undergo an invasive procedure before vitamin K could reverse the warfarin effect, or who need only transit reversal of warfarin effect. So for
I did again. 146.
Please mute. I really have a small time. I need to finish her. We still have a lot to cover. And then the guy for transfusion or plasma exchange in patients with so again, we say these particular patients they're having thrombotic thrombocytopenic purpura. This is where now the patients have produced antibodies which are destroying the donor transfused platelets. So if we need to continue transfusing, they have refractory thrombocytopenia. So again, in such case, you give FFPs. At least FFPs will remove those particular regular antibodies in the system of the patient. So management of patient with selected coagulation factors deficiency, congenital or acquired, for which no specific coagulation. Again, in such a case where you're not able to find specific coagulation factors deficient for that particular patient, then now you FFP. Then management of patient with rare specific plasma protein deficiency, again, because remember in the plasma we have all the plasma protein, the albumin, the fibrinogen, the immunoglobulin. Definite indications include replacement of single coagulation factors deficiency where specific or combined factor concentrate is unavailable. So in that case, there is no alternative. So there you have to do FFP. So again, you are having a patient who is due for procedure and they are on warfarin and you need to revert that particular effect of warfarin so that they don't overbleed during the operation, then you will go for FFP. That is immediate reversal of warfarin. Again, in consumptive coagulation factor deficiencies, like in DIC, that is acute disseminated intravascular coagulation, will need FFP, and then thrombotic thrombocytopenic purpura, stroke hemolytic uremic syndrome. Those are mostly immune thrombocytopenia. So they are, in such cases, we need FFP instead of transfusing platelets. So conditional use only indicated in the presence of bleeding and disturbed coagulation. So these are conditional use. In liver disease, which means you don't just say this patient is having liver disease, we are going to do a plasma transfusion. In such case, it is conditional in massive transfusion and also in cardiopulmonary bypass surgery. So contraindication, do not use this product when coagulopathy can be corrected more effectively with specific therapy. So where the specific therapy is available, like where you can use vitamin K, you can use cryoprecipitate, or specific coagulation factors, you give that. Then FFP should not be transfused for volume expansion. If you are interested just to expand volume, you go for the crystalloids, you go for the saline, you go for the all those fluids. So you don't go for albumin. Albumin is a good volume expander. So when blood volume can be safely and adequately replaced with other volume expanders, you don't go for FFP. You also don't use FFP as your nutritional supplement. Don't use it prophylactically with massive blood transfusion. So this has to be clinical judgment. Or versus if you are able to mute the person, then prophylactically following cardiopulmonary. So what do you need to consider? The plasma should be recipient IBA, RBC, ABO compatible. Now the plasma has got antibodies. So if it is not compatible, then you will have a very bad transfusion reactions. So in children, should also be rhesus compatible. Then the dose is about 20 cc per kg to raise the coagulation factor by approximately 20%. So the next one we look at is cryoprecipitate, as much as we've also mentioned a bit of it in the plasma component transfusion. So for the cryoprecipitate, it contains, we had said how it is prepared. It is a precipitate prepared by thawing the FFP between 1 and 6 degrees. And then once you thaw at that temperature, you centrifuge, then remove the plasma, and whatever remains is your cryoprecipitate. Just a small volume that will remain, about 10 ml. And that one contain about greater than 8 international unit of factor 8 units and greater than 150 milligram of fibrinogen in approximately 5 to 20 ml of plasma. So it contains factor 8, very rich in factor 8, 80 to 100 international unit of the same. It contains fibrinogen, factor 13, fibronectin, and von Willebrand factor. So this will be indicated for those patients with having von Willebrand disease, the patient with hemophilic disease, they will be given cryoprecipitate. So storage after collection, it can be refrozen and stored up to 1 year at -18. And this one you may need several units of FFP to prepare. So 10 individual units is a standard adult dose. So cryoprecipitate is used to control bleeding associated with fibrinogen deficiency. Where this patient is having hypofibrinogenemia, then you will correct that using cryoprecipitate. Patients which are also suffering from factor 13 deficiency, we correct using cryoprecipitate. It can also serve as a second-line therapy to von Willebrand disease, hemophilia A, where there is factor 8 deficiency, DIC with active bleeding or before invasive procedure, and the APTT is greater than 1.5, the normal ranges. In hypofibrinogenemia, as we have said, or uremic thrombosis. And this is hypofibrinogenemia, and they're also unresponsive to desmopressin with active bleeding or before scheduled invasive procedure. In von Willebrand disease, and again, they are unresponsive to desmopressin, and the patients are actively bleeding, which means this patient is having von Willebrand disease, they are actively bleeding. We've given the desmopressin and the patient is still not responding, then at that case we'll do a cryoprecipitate transfusion. So again, in factor 13 deficiency, And the ones which are having fibrin blues, fibrinogen deficiency or dysfibrinogenemia, which means fibrinogens are in normal count but not functioning normally, and then in factor 8 or factor 13 deficiency. So in contraindication, where you are not supposed to give it, should not be used when factor 8 concentrate or recombinant is available. So when you have factor 8 concentrate, then you give factor 8 concentrate, or recombinant factor preparations are available for the management of patients either with Willebrand disease or hemophilia A. So if you're having these particular combinations, these particular factors concentrate, then you can give instead of giving cryoprecipitate. So again, it has to be Hebio compatible preferred, but not limiting. The dose is about 1 unit per 5 to 10 kg. So other plasma derivatives, so we have got plasma fractionation products, which means if you use that particular plasma in industrial setup now, and they do fractionations, we are able to come up with other products in pharmaceutical industry from FFP. So some of the things we're likely to derive or rather manufacture from the FFP or plasma products include albumin, immunoglobulins, the factor 8 bypassing activity, antithrombin, fibrin sealant, like the ones, fibrin sealants are the ones used in surgery. You can use that to spray the surgical beds where the patient lies, or even around the areas, the areas that are being operated. That is just meant to minimize bleeding. And you can also have protein C. So these are just albumin, it's a volume expander. We talk about factor 8, that is in hemophilia A. That's where you give it. And then you can also have the, I'll not go much about that because just what we are aware of. These like this one here is a recombinant. It's a combination of factors. So you can have that concentrate recombinant, and it will have factor 8, factor 9, factor 10, factor 9 and factor 10, and you can give it to patients who are deficient of those particular factors, or even in some fibrinogen, and for patients which are having those particular factor deficiencies, then you can give those recombinant factor concentrates. For immunoglobulins, IgG antibodies for IV or IM use, and these ones you can give in patients with a gamma globulinemia, those ones having low immunoglobulin levels, that is hypoglobulinemia, and also patients with immune thrombocytopenia, as we had mentioned during our discussion. So RESAs, these ones we all know, the ROGAM that is given, the IgG anti-D, and that is used for prevention of innovative disease of the newborn due to the D antigen. So again, for the storage, FFP, you store at -18 up to 1 year. So this is what I was talking about, plasma frozen within 24 hours after phlebotomy. So this means that this plasma was prepared from a unit that has overstayed for more than 6 to 8 hours. So it's no longer a fresh frozen plasma. So if it is labeled that way, the person who will be issuing it will know if it is FFP that is required, then they will not give it. But if it is just to replace other coagulation factors, then we give plasma frozen within 24 hours after phlebotomy. Again, apheresis FFP, that one is obtained direct. Of course, cryoprecipitate, the same. That's talk about just the storage conditions for those particular plasma products. Maybe we'll share the slide so that you are able to interact with them at the table. Then here we have got granulocyte concentrate. This is rare. I don't know whether in Kenya we do, but if you are going to have this, then the donors must be given the GCSF, that is the granulocyte colony stimulating factor. So to increase the production of this particular granulocytes, so that before harvesting by through the apheresis. So this is not done the manual way. It's harvested by apheresis and only indicated to the patients with the multiple drug resistant, which means these patients are suffering from bacterial infections, and they are not non-responsive, or rather unresponsive to antimicrobial therapy. And as we have said, the donor is given GCSF and steroids. So complications could include severe allergic reactions and can also be irradiated if you are going to give it to a patient who have received a transplant patient. Then you need to irradiate. Remember, here you are now giving granulocyte. So it's very key that you irradiate those products if the patient is immunocompromised. So apheresis granulocytes you store within at a room temperature without agitation. Even apheresis granulocyte irradiated the same, but you give within 24 hours. So it means that this is something that has to be prepared. We cannot do it like the one that it requires that we plan for the same, like the normal transfusion products that we do for the red cells and the other products. Again, we talk about lipodepleted blood. So these are special requirements, and that it is necessary that we try to lipodeplete almost all. So all unit will have about that, but after liporeduction, we will reduce it to less than 5,000 of leukocytes. This is by filtration or pre-storage, and then cryoprecipitate and fresh frozen plasma do not contain intact or viable leukocytes, and so therefore you don't need to lipodeplete this particular two products, the FFP and the cryoprecipitates. So these liquid-depleted products are used for prevention of transfusion reactions, and other plasma proteins such as albumin, colloid expanders, factors, coagulation factors also do not need filters, so we don't need to liquid-deplete that. Then never use filters with stem cells, bone marrow infusions, and thus may reduce the RBCs by 5 to 10%. And do not prevent graft versus host disease. If your target is preventing graft versus host disease, then you do irradiation of those particular products. So when you give leukodepletion, or when you do leukodepletion of blood components, one is for patients who have experienced 2 or more non-hemolytic febrile transfusion reactions, all neonatal and pediatric transfusion for children less than a year, and the purpose of transfusing leukocyte depleted blood products. One is to reduce the HLA alloimmunization to leukocyte in a multiple transfused patients. So this patient could have received a multiple transfusion and they are now hollow. They are likely to have transfusion reactions. That's why we try to reduce we try to leukodeplete those particular red cell products. Then another thing is to reduce the risk of cytomegalovirus transmission, especially if it is transplant patients or immunocompromised patients. Again, it will decrease the febrile transfusion reactions and used to prevent alloimmunization by leukocyte antigens. So this other one we've talked about for the irradiation throughout our presentation. So irradiated blood products are exposed to approximately 2,500 rads of gamma radiation to destroy the lymphocyte's ability to divide. And irradiation will destroy the ability of the transfused lymphocyte to respond to host foreign antigens, and so therefore preventing the graft versus host disease in susceptible recipient. Remember, if the lymphocytes are competent enough, they'll be able to attack the recipient's cells, and so therefore causing graft versus host disease. Then patient with functional immune system will destroy the foreign lymphocytes, and irradiation will be unnecessary. So this is indicated for patients who are immunocompromised and also patients who have received bone marrow transplant and things like that. Then transfusion associated graft versus host disease has not been reported from transfusion of cryoprecipitate or fresh frozen plasma. So therefore, these particular components will not require any irradiation. So what are the absolute indications? As we had mentioned earlier, it is BMT, that is the bone marrow transplant of stem cell donors, if allogenic transfusion must be given prior to completing the harvest. So again, even that case where you want to give you found a donor for a bone marrow transplant patient, but maybe this particular donor, they may require transfusion before they can actually do the procedure of donating. Then in that case, the units we are going to use to transfuse that particular donor has to be irradiated. Then intrauterine transfusion, I had explained that one early. That one we need to irradiate. Remember, it is a fetus and their immune system is not fully developed. Then transfusion from family members, any degree, and that is 2 to this particular group of patients we're talking about, the bone marrow transplant patient, the stem cell transplant patients. The HLA matched platelet transfusion, we had explained that under the platelet transfusion. Then appropriate indications, it can also be given in cases of hematologic malignancy like in leukemia, those patients with the Hodgkin disease and non-Hodgkin lymphomas, neonatal late-stage transfusion, and premature infants. If you are to do a transfusion of the same, then you need to do irradiated blood for that. And in certain solid tumors such as neuroblastoma and glioblastoma. And that marks the end of our presentation for today. So knowing is not enough, like what we have talked about. We must apply. Knowing is not enough. We have attended the webinar. We have acquired the knowledge. We should apply the knowledge on our bench. Willing is not enough. We must do. Yes, we have the knowledge. We are willing to do. So that is willing alone is not enough. It's not going to make any change to our practice. So we must do through this webinar. And that was the quote by Johann von Goth. And the references are there. You can interact with them at your own time. Otherwise, I want to thank all of you. And most important, let's donate to save lives. As you can see, that one single donation can give us several blood components. From it, we can harvest the FFPs, we can harvest the cryoprecipitate, we can harvest the platelets, we can harvest granulocytes, you see, and all those platelets can serve. That one single bag can save several lives, which means that single bag can go to a patient who require RBC, a transfusion, that is an anemic patient, and one life. That one bag can go to that one which require a plasma transfusion, FFP, for example. Another one require thrombocytopenic patient, they require platelet transfusion. The one which is having multi-drug resistance, you see. So all that. So back to you. And I hope all of us have enjoyed this session.
Thank you, Doc. I think that has been a lot of insight. Just from my end, since it has been like a year since I worked in a blood transfusion lab or transfusion center, it has been really a
Since I lost you.
from my end, it has been a year now since I worked in a blood transfusion center. This has been very refreshing. And I can see even from the comments, it's a very positive comment. People have enjoyed the topic, as I said earlier. Francis is a specialist in this area, and this has been a lot of information from our end. Just to add on the same, we have a few concerns and a few questions from the chat box. And before I read that, kindly, if you can give a little comment on the recent research I had that we have a section where a stem cell are being produced to give people donation. Before I read the questions from the chat box, thank you.
The stem cells are being produced to give.
I read an article from a particular wall that we have some stem cells. It's a research ongoing that we have some stem cells that are being used to create or to produce RBC. Maybe you can just give a slight note on that. Here, from my end, I just wanted to inquire, like, how many points of blood maybe are just required to raise a gram of HB?
Okay, well, let me start with the last one. Okay, for one unit should be, yeah, one unit is required to raise at least 1 gram. Yes, 1 gram of HB. And then for the stem cell, yes, okay, I'm here to look into that research. Maybe I'll also try to read around it and see what the people working around it, what they discuss. But of course, it is possible because it means, remember, the cells are formed from the stem cell. So this particular stem cell, we start with the pluripotent stem cell, and then the pluripotent stem cell will differentiate to give us the multipotent stem cell. Then the multipotent stem cells is the one that now differentiate to different cell lines. So now we move to the actually it's the megakaryoblast, the granulocyte colony stimulating factor, that particular stem cell, then it will differentiate and give us the erythroid. So if at all that for us to form the RBC, then we need to have a stem cell that is committed, a progenitor stem cell that is committed to the erythroid cell line. Then of course at the end of the day we'll have the red cell being produced in the lab. That is possible, but how we do about it, of course, scientifically it is possible provided we have the right stem cell. So that will require flow cytometry because we need to know the cluster differentiation for that particular stem cell. The CD34 is the general one, but now we move to go down to the specific one, the cluster differentiation for the stem cell that is committed to the erythroid cell line that will differentiate all the way from the erythroblast to the erythrocyte finally. Yeah. So the next question is. And this stem cell, by the way, now that you bring a topic, it's only that technologically we are still down. Stem cell can really save us a lot, even in terms of sickle cell management, even in terms of the hematological cancers like leukemia, the CML, and all that. So maybe in future, I don't know, in future, if we reach a point where we can have a stem cell bank, then we can be harvesting, because remember the embryo, that placenta, the umbilical cord, it normally has a lot of stem cells. It can be harvested, stored, so that the patients who need them, or even that particular child that has been born, if at one point they need a stem cell transplant, then they will not need to look for a donor. They will just use their own stem cell. At what level is transfusion considered for ANC mothers, especially for those who are almost in trimester? So this one I will answer carefully because it will depend on the evaluation of the attending clinician and also the clinical status of that particular mother. Because the mother could be having an HB of 8, but again, there's now the decompensatory syndromes like tachycardia. There is call it what hypnea, where the patient is not able to breathe well and all that. So in such a case, they may need to be transfused. Again, remember, if this mother is having an HB, they are in third trimester, and they're about to give birth, it will not even be advisable for them to go the normal way. So in such a case, they may be advised to, the best method would be CS. At least from there, the doctor will be able to control the bleeding, and they are not likely to suffer much loss of blood. So in such a case, if the HBs are falling below 8 or even 9 and it has been boosted, it is not responding, then and the patient, maybe the only available option is to deliver through the normal route, then that particular patient might need transfusion prior to delivery. So this will depend on several factors, depending on the clinical status of the patient. Yes?
Thank you, Doc. I think this also from Dorcas, David Odur, relate to the same, is asking an indication for transfusion if it's less than 7 grams or 5 grams per deciliter. Just an indication of when to transfuse. I think it relates to what question you have answered, but you can add more.
Yeah, so for the indication of transfusion, that one we have said, okay, you see, like if you are practicing in Nairobi, mostly HB of less than 6. That is for the normal population. We'll consider that an indication of transfusion. So we really need to do a study of reference interval so that we are able to know what is the normal ranges for our population. But to see the HB levels in Kisumu is not likely to be the same as the people who are living in the Mount Kenya region. So depending on where the situation is, I mean, depending on the location in the HB reference ranges for those particular courses to vary. Anemia is defined based on the HB ranges and also based on the geographical areas. Because if they're in highland areas, they tend to have very high HB. So maybe even the cutoff could be higher. Maybe even an HB of 8 could be considered anemic for that particular population. And like the people who are in lowland areas, those ones don't have that very much HB, and 6 would be severe in such a case and all that, you see. So depending on where the location of the patient, the clinical status of the patient, again, if the patient is having other comorbidities, yes, they're having an HB of 6, but they are sickle cell patient. You don't transfuse simply because they're having an HB of 6. But again, if this is a sickle cell patient, the HB is dropping below 5, then in that case you transfuse. So decision to transfuse will depend on both hematological and the clinical status of the patient. Yeah. The next one.
Thank you. Thank you. This one is from Margaret Nechesa. She's asking, is it advisable to transfuse FFP, fresh frozen plasma, to thrombocytopenic patients?
Thrombocytopenic patient.
Is it advisable to transfuse fresh FFP to thrombocytopenic patients?
Thrombocytopenic patients, if you look at our discussion on platelet transfusion, we have said, yes, if it is definitive, which means this patient is having thrombocytopenia, nothing on the side, then in that case, I mean, nothing on the side, then in that case, you don't give FFP, you give platelet transfusion. But if this patient is having immune thrombocytopenia, yes, they are thrombocytopenic, but it is immune thrombocytopenic purpura, such cases, you give FFP, you don't give platelet transfusion. So it depends with the clinical condition of the patient. That is what will guide the product that we are going to give in such a case. Yes. Next one.
Thank you, Doc. This is from, and he's asking, do you have any cases in Kenya where we have gotten a patient who have reacted to all blood groups? Okay, maybe considering to other blood group types, do you have any patient in Kenya who have reacted to all blood groups? Like, do you have any case from your end?
No, the only way that we know that this particular patient even in Kenya, we have got transfusion reactions. So those transfusion reactions, we take them back to the lab and we investigate. So during our investigation, if we find that the transfusion reaction is taking place at, let's say, SR, I mean, let's leave SR, that is more direct, that is ABO. So it is taking place at AHG. So that is Rhesus incompatibility, because that is what we are testing for. So we'll say this is the Rhesus incompatibility, but it could not be Rhesus. It could be other blood group system like anti-KEL. It could be anti-DAFI. You see, it could be anti-DAFI, or it could be the MNS system. That is the S system, the anti-S. So yes, it is possible, only that we are not screening for the other blood group system. So the face will tell you. For those ones who have done ACPI, you will understand further that in such a case of a transfusion reaction, we'll do what are ICTs. We will try to do the indirect Coombs test just to find out if these particular patients have got irregular antibodies towards the donor, regular antibodies. And then if you find that this patient is ICT positive, which means even before our transfusion, this particular patient is allo-sensitized. So now at that point, you don't know what antibody is responsible. And that's now where you go and do the antibody screening. If you remember the antibody identification panel, that's the panel. So with that panel, you are able to know if it is anti-DAFI, it is anti-KEL, or it is anti-C, big C or small e that is responsible. Because even for the rest, we are not investigating everything. We're just looking at the antigen. It could be anti-C. It could be capital E or small e. Yeah. So until we get to that level of investigation, we have them. As long as you are a human being, you have all those other blood group system in our system, and they are possible to cause transfusion reactions. But now, Sasa, that's why we are saying normally you see people because of workload, when they're doing the cross match, they just want to do their SRT and that's it. And some of them are even kept it a practice within 30 minutes, 10 minutes. You are done with your cross match. You are doing a lot of injections. You're just screening for the ABO or those particular antibodies that are able to react at room temperature. But you are missing on a huge chunk of possible antibodies, the ones that are react at 37 degrees Celsius. That is the IgG antibody. The rhesus antibodies, the anti-KEL, the anti-DAFI, the KID, all those. So we need to take care of the 4 phases. So as much as we are not screening, but at least we will know there's a reaction. Yes.
Okay, thank you, Doc. We have a lot of concerns, but because of time, I will just read this one and then we call it a day. But let me read this one from Evans Ongonyo. He's asking, does transfusion of apharetic platelets require blood group specific or it's for any blood group? Does transfusion of apharetic platelet patients, I don't know if he has right PLTS, I don't know if it's platelets require blood groups specific or it's any blood group?
Yes, the transfusion of apharetic platelets require that if the patient is blood group A, the apharetic donor should be blood group A. If the patient is blood group B, the apharetic donor should be blood group B. But now, depending on your hospital policy and where you are practicing, because again, finding apharetic donors also is not an easy thing. So it means that within your pool, you could be having a patient who require A, and then their donor is blood group B. And then another patient is require the same B, but their donor is blood group A. So then in that case, these two apharetic donors can donate. You prepare the products and give the one that match the patient, which means the one that requires the patient that will require the platelets blood group A, you give them their same type. You don't interchange, and that is very key, especially for apharetic. So we have to ensure it does not require specific blood group, yes, but the blood group is determined by the type of the patient blood group. If the patient blood group is A, the platelets or the apharetic platelets we are giving should be of type A. Yes, it should match the patient blood group. The next one.
Thank you, Doc. I think we are at time, and thank you for your today insight in regard to blood transfusion science and choosing the right component to the right client. I think this has been a lot of insight, and we shall encourage, and maybe we'll have another webinar in regard to blood transfusion and the components, preparation, and anything in touch with blood transfusion. I have seen a lot of concerns for people asking to send the slides to the email. We have captured the email, but I may also say that this webinar is recorded and you can access it free of charge on the YouTube channel. You can listen any multiple times. You can refer to it. Just at the close of this webinar, you can access it. And also just to remind the participants that this webinar, you will get your points within 24 hours. That is, by the end of tomorrow, you shall be credited to your points. I just want to welcome Francis to give his final remarks before we close the webinar.
Yeah, I just want to thank everyone, but this one is very insightful. I'll share the slides with you, so you can try and capture those ones who had shared their emails. Then you send them. At least it will help them, because this is something that is reality of the ground. So maybe they would really want to take time and go through the slide. Otherwise, I don't want to add much on what we have said, because every point we've discussed in this particular webinar is very key. In some areas I had to rush because of time. I will not really take much time to go into the nitty-gritties, especially on some of the tables, but it's nothing much. It's just talking about the storage conditions and all that. But the key elements that you need to know, we have highlighted them out. So we would want to go back to the same quote: knowing is not enough. So we've attended the webinar, we've acquired the knowledge. That is not enough. We must apply. Willing is not enough. We must do. So you have the knowledge, you have applied, but you are willing, but you are not doing. So you see, the only way we are going to impact our practice if we do. So knowing is not enough, we must apply. Willing is not enough, we must do. Thank you all. Have a good evening.
And thank you for joining. I welcome you to another presentation.
Yes. طلع. ¿Qué yo gusto? Firi. Sasa na hapa. Mfungo hii ya juu.